So multimorbidity is the presence of two or more long-term health conditions. These can be physical or mental health conditions. So to give some examples, here in the UK, over half of people with diabetes also have hypertension, so that is high blood pressure. A third of people with dementia also have depression, and a quarter of people with heart failure have atrial fibrillation. That's an irregular pulse that can raise your chance of stroke. In addition to these, many people with chronic long-term conditions also suffer from frailty or a complex pain syndrome of one kind or another. And multimorbidity matters because it's associated with a reduced quality of life, higher rates of mortality, having to take lots of drugs, polypharmacy as it's called, with all of the associated side effects, unplanned hospital admissions and higher healthcare costs for the provider. And of course, as populations are aging and as non-communicable diseases, so NCDs, they're on the rise, healthcare providers are finding that multimorbidity is becoming the norm rather than the exception. People are living longer with diseases that once may have killed them, and this is good news, but it provides a challenge for evidence-based medicine. So evidence-based medicine is a process of systematically reviewing, appraising and using clinical research findings to inform the delivery of care. It's making sure that when decisions are made, they're made on a basis of the most up-to-date, most solid, reliable scientific evidence. And for many people, the heart of evidence-based medicine is the production of evidence-based guidelines. So guidelines, they're a document produced by an authoritative institution such as NICE here in the UK, with the aim of guiding decisions and criteria regarding the diagnosis, management and treatment in specific areas of healthcare. The challenge is in the word specific. Guidelines are produced using the best evidence available for certain conditions, and because trials are designed to target one particular factor, the variable that is being tested, trial evidence tends to focus on the impact of a certain disease, one single disease, and guidelines are therefore produced for these individual diseases. But of course, people with multimorbidities do not, by definition, have one specific condition. They have multiple conditions. There have not traditionally been any guidelines on how to treat people with multiple conditions, and that's because of the limitations of the evidence base. And so if health professionals were being studious in following guidelines when treating multimorbid patients, they would apply the recommended course of action from each applicable individual guideline to the patient. However, that leads to obvious difficulties. So, for example, if guidelines for patients with disease A recommend treatments 1 and 2, guidelines for disease B recommends treatments 3 and 4, and guidelines for disease C recommend treatments 4 and 6, then the patient may end up with having all 6 therapies. And that's often why people with multimorbidities end up having a kitchen cabinet that resembles a fully stocked pharmacy. And so no wonder the management of adverse drug effects and drug-drug interactions cost health services so much money. And of course, it's a massive inconvenience to the patient. However, so far I've been describing EBM really as cookbook medicine, which is how it's sometimes critiqued, wherein health individuals will blindly follow recommendations derived from the evidence. However, this is doing both EBM, evidence-based medicine, and health professionals a massive disservice. Evidence-based medicine in practice integrates the best available research with the clinical experience of the physician and the patient's values. So at the moment, general practitioners have to manage these issues via their experience and judgment. However, NICE decided it would be helpful if they were offered some guidance. So the multimorbidity guidelines, they've been in a pipeline for several years. Actually, NICE admitted that developing the recommendations took longer than expected because of difficulties extracting relevant advice from all the existing single condition guidelines. But it starts by describing the size of a challenge to the NHS. So it says about 3 million people are predicted to have 3 or more long-term health conditions by 2018, and at the average health and social care costs for these people is going to be around about £8,000 per year. It also reminds readers of a principle that patients should be involved at the heart of decisions about their care, which is good advice for all patients, not just those with motor morbidities. Recommendations of a guideline include things such as stopping treatment if it's considered to be of limited benefits, try to identify medicines that have a higher risk of unwanted side effects, and for those, you see if you can reduce them or observe side effects very closely. Offer alternative treatment, particularly non-pharmacological, so non-drug treatment, compared to some medicines. Consider making alternative arrangements to make the best use of appointments a person has to attend, so they don't have to prioritise conflicting appointments for different conditions. The guideline outlines where it's appropriate to offer an individualised management plan, so factors that should be considered include the number of prescribed medicines, how often the person needs emergency care, and how difficult it is to manage their treatments on a day-to-day basis. So in a way, the guideline outlines a structured approach to what providers are already doing. It also reminds us that EBM is not only the scientific evidence, which is critical and must remain so, but also the patient's values and priorities, and crucially the expertise of the healthcare professional.